Hello and welcome to Quality Reporting Deep Dive, a webinar sponsored by Cardinal Health Specialty Solutions. Today, we'll review MIPS quality measures and benchmarks and hear real-world practice perspectives on preparing for quality reporting success. This webinar is part of our three-part MACRA webinar series. If you missed our first webinar, MACRA Bootcamp, we'll send a link to you following this event. Our next webinar, Exploring Advanced Alternative Payment Model Opportunities, will be held Thursday, March 2nd, and invitations will be sent soon. Before we begin, please note that the conference line will be muted to reduce noise. To submit questions, use the chat feature in the lower left-hand corner of your screen. A recording and copy of today's slides will be emailed to you after the event. Now let's meet today's hosts. Dr. Bruce Feinberg, Vice President and Chief Medical Officer from Cardinal Health Specialty Solutions. Martie Ross, consultant from Pershing Yoakley Associates, and Robert Baird from Dayton Physicians Network. A nationally recognized expert in oncology, Dr. Feinberg established and led one of the largest integrated oncology practices in the southeastern U.S., is a best-selling author, and regularly published in peer-reviewed journals. Martie is a MACRA expert and consultant from Pershing Yoakley Associates and has 2 decades of experience as a healthcare transactional and regulatory attorney. Martie serves as an advisor to healthcare providers navigating today's complex healthcare landscape. Finally, we have Dr. Robert Baird, CEO of Dayton Physicians Network. He has extensive experience in healthcare management, developing strategic plans, and directing financial, operational, and clinical initiatives. He leads one of Ohio's leading multi-specialty cancer treatment centers and specializes in hematology, medical oncology, radiation, oncology, urology, robotics, pathology, and imaging. The physicians at the practice have those specialties. So please welcome today's hosts, and now Dr. Feinberg will get us started. Dr. Feinberg?
Thank you, Keith. Welcome, everyone. For those who joined us for the MACRA Bootcamp, I think you'll find today's equally impressive. Martie's done an amazing job, and we have preparing the materials, and Robert's also a great asset because he can give you some of the hands-on experience that he and his practice have dealt with. They are an OCM practice. OCM is an advanced model, an advanced payment model that's been released for oncology. Much of the reporting requirements in APM are similar to those in MIPS, so Robert has some great hands-on experience he can share. We're going to start as Martie kind of touches base with the last presentation by beginning with the 2016 Physician Quality Reporting System, PQRS, and those reporting requirements and how they're going to dovetail into the future models. Martie, take it away.
Thank you, Doctor, and good morning or good afternoon, everyone. Glad you're able to join us for Part 2 in our webinar series. As we discuss MACRA, we need to keep it in context of what it's replacing. So our new MIPS system, the Merit-Based Incentive Payment System, is going to replace 3 programs which are probably near and dear to your heart, which include the Physician Quality Reporting System, the Medicare Value Modifier Program for physicians, and finally the Meaningful Use Program for physicians. And it's important to appreciate what MIPS brings forward from those programs, but also to appreciate what changes from those programs today. So we thought as we were going to talk and doing a deep dive here on the quality reporting requirements within MIPS, it made sense to spend a few minutes to put that in context by summarizing the requirements of the Physician Quality Reporting System, or PQRS. And believe it or not, PQRS started back in 2006. So we've been on a 10-year journey with physician quality reporting. Now initially it was good news because it was a bonus payment to physicians who submitted quality data to CMS. But as part of the Affordable Care Act, the program morphed into a penalty. And so that for the last several years, if individual physicians and groups have not submitted data through the PQRS system, they have been penalized 2% on their Medicare physician fee schedule payments. So next slide, please. So despite all the noise around MIPS, don't lose sight of the fact that we are still under the requirements for PQRS. And in fact, we are now in the time period for submitting 2016 data so that you avoid that 2% PQRS penalty in 2018. And also remember, if you don't submit your PQRS data, you automatically receive the negative 4% adjustment in the physician value modifier program. So you take the lowest, you take the highest penalty automatically under that program. So failure to report PQRS now here in the first quarter of 2017 on 2016 performance can result in will result in a negative 6% impact on your Medicare physician fee schedule payments. And here you have on the screen the deadlines for submission of data. In most instances, that deadline is March 31 for pulling that data together. So if you have not begun that process now, we are certainly now in a state of urgency with regard to that information. Next slide. As you may recall, PQRS provides two options for reporting. And the first option is that a physician or a group practice report on at least 50% of their Medicare patients. And for those patients, they have to report on at least 9 individual measures, one of which is a cross-cutting measure, cross-cutting referring to common preventative services and care. Those 9 measures have to cover at least 3 national quality strategy domains. So you're already getting into upper level math here, just trying to figure out how to select measures in this first option. Now more recently, PQRS created the measures group alternative reporting system so that a group or physician can report for at least 20 patients, at least 11 of whom must be Medicare patients, on one complete measures group. And so obviously if you utilize the measures group, you are reporting on a much smaller number of patients. And so it has been much more manageable, and for the most part groups and practices have migrated over to the second option. Next slide. For those who have selected the first option of reporting on individual measures, there are general guidelines offered within PQRS by specialty. So there are 17 measure sets that CMS identified selected by practice. Those are merely a guide to help specialists identify measures on which to report. One of the criticisms of PQRS for several years is that it was at a strong primary care focus and was less relevant to specialists. And in the last 2 years, CMS devoted significant effort to expanding the measures that would be applicable to specialists and highlighting those measures. So as of today, PQRS sets at 275 measures. And again, as you look at those measures, you will see them divided across 6 domains of care. Next slide, please. If you choose to do the measures group reporting, you select from one of 25 identified groups. There are measures, the number of measures in each group varies. For example, for oncology, the measures group has 7 measures in it, while rheumatology has 9 measures included in it. This is registry-based reporting only, where you have a 20-patient sample that is identified, the majority again of which must be Medicare patients, and you have to report on all measures for each of the patients. You must have a numerator of at least 1 for the measures to be satisfactorily reported and thus meet your PQRS requirements. If you cannot report the full set of measures for the identified patient base, you will have to instead use individual reporting. Next slide. Over time, CMS developed multiple reporting mechanisms for PQRS using a separate approach both for individuals who are reporting and group practices who are reporting. You see here those different methodologies available for submitting data to CMS. Next slide, please. The manner in which you participate in PQRS, i.e. whether you submit your data individually or as part of a group practice, impacts how the adjustments take place. So if you participate individually, your payment adjustment will be at the individual MPI level. And so as you submit claims, it will attach, your PQRS adjustments will attach to your MPI and reduce payment accordingly if you are subject to the penalty. If you are involved in a group practice reporting, it is instead applied across the TIN. The implications then for the value modifier program are more complex, since the value modifier program assigns the adjustment at the group level only. So while PQRS adjusts either the individual level or the group level, depending on the reporting mechanism, the value modifier program applies only at the group level. And thus, if you have, for those groups whose participants elected to report individually, the determination of the adjustments for the value modifier program is based on whether at least 50% of the group's providers reported successfully within PQRS. Next slide, please. So needless to say, even at its most simplistic level, PQRS can be a very confusing program. And many providers have taken the hit of the payment adjustment because they do not feel they've been able to marshal the necessary data for reporting purposes. It is fair to say that the MIPS quality reporting requirements are significantly more straightforward than PQRS, and that they have in fact simplified the process. That's not to say there isn't room for additional simplification, but the good news here is that this is a more straightforward process. Next slide, please.
Marty, before we get into the MIPS, I'd like to get Robert.
Oh yeah, absolutely.
You mentioned, that most practices that have chosen the group measures. And Robert, given the fact that you are a large, sophisticated practice, I would think you would have done that. And I'm also curious if you would comment that in regard to PQRS, my experience is that the doctors have not been heavily engaged, that this is more of a management team function. But I'm curious in your practice how that's worked.
Yeah, so actually our practice, because we're across different specialties with medical oncology, radiation oncology, and urology, we did choose the individual methodology to report. And so that just worked out better because we tried to find some measures that crossed all providers, but some additionally did not. So we've actually been pretty successful doing it that way. I think you're right that we did most of this and set up the workflow on the back end and did not really involve our physician providers or our providers that much. So a lot of it fell on the administrative and clinical staff to capture and make sure they're clicking the boxes in our system.
And so a final question before Marty moves on to MIPS. Were there any learnings from the back office team as they were completing the registry information where that led to any changes in the practice?
Well, yes, and I think one of the things we learned through this process is we did report directly through our EHR, and it actually does have a pretty decent, because PQRS was applied to all physicians, it has a pretty decent PQRS MU2 module that we were able to utilize. And I think one of the things we learned as we set this up, as quality reporting became more complicated and more clinical measures were required, we set up a lot of our workflows to go around the clinician, so we didn't want to interrupt their day in their workflow. And so now we're having to go back and redefine those workflows and re-educate providers on the requirements for data reporting, because there's you just can't have a medical assistant put in some information. A physician has to make some of those determinations. And then also just being consistent in doing this.
Appreciate that, Robert. All right, Marty. So tell us about MIPS.
Oh, okay. So first piece of the story is to remember how the MIPS final score components fit together. Remember, that's the end game in MIPS, is that score assigned to each MPI between 1 and 100. And that final score for 2017 will be based on 3 components: quality, clinical practice improvement activities, and advancing care information. Advancing care information is the new name for meaningful use. As you can see in 2017, that final score is going to be comprised 60% of the quality score. So it definitely carries a heavier weight. As we move forward in 2018 and 2019, the importance of the quality score is diminished as the importance of that 4th category, the cost performance, comes online. Remember from our discussion last time, the MACRA legislation mandates the 30-30-25-15 split, with quality and cost performance equally weighted at 30%. But CMS had the authority to phase that in over time, and it exercised that authority beginning in this first performance year, 2017, assigning 60% of the weight to quality and putting cost performance at 0. But appreciate over time the cost performance percentage will increase from 10% in 2020 up to the full 30% in 2021. And again, CMS's reasons for doing that was just the lack of sophistication in the measures to generate a cost performance score. And certainly there's a great deal of work being done in Baltimore right now around developing that infrastructure for that reporting and calculation of scores. So if you're looking at a 60% of your score, it's certainly reason to pay attention to where we're moving on quality reporting. Now, before we get into the details of quality reporting and measure selection, it's important to highlight that 2017 is considered a transitional year between the 3 prior programs we discussed earlier and now MIPS. And in that regard, CMS adopted the pick your pace approach for this year, meaning that a individual physician or non-physician practitioner who's under MIPS has the option of simply reporting on one single measure to avoid the negative adjustment. So just like PQRS, where if you failed to report, you automatically received the full negative penalty under the value modifier program of 4%, the same is going to be true with MIPS. If you do not submit any data, then you're automatically going to have that 4% penalty. For 2017 and 2017 only, if you report on one measure for a minimum of 90 days, you're going to zero out, meaning you will not have any penalty assessed against you. You have the option to go ahead and submit the full set of required data. And certainly we would encourage practices to do that, to use this pick your pace year as a practice year in terms of selecting measures and gathering data and submitting information. So if you in fact do submit all of the required measures and you score well on those measures, you then have that opportunity to earn that full bonus payment of 4%. And in fact, that bonus payment could be above 4% because of the scaling factor required by budget neutrality. Also, if you find yourself in the very top performing quartile, and for this performance period it's those that have a final score above 70, you're going to be eligible to participate in a $1.5 billion pool of funds that are available to incentivize top performance. So here's your first decision point for MIPS in 2016, is whether you're just going to ignore completely what's required here and automatically take that negative 4% hit. If you're going to put your toe in the water and at least report on one measure to avoid the 4% penalty, or if you intend, again, to use this as a full-scale practice year with that opportunity of earning the full bonus payments.
Yeah, this is Robert. In our practice, we discuss this with our physician leadership and our administrative team, and we are, like I'm assuming most practices would try, we are going to try and submit for a full year, and then we're going to kind of gauge where we're at, and if we have to, we'll at least do the 90 days as a backup. So that's our goal.
It's a great starting point. Just like PQRS, MIPS is going to be on this cycle of perform, submit, and adjust, so that we are now again in the first performance year of 2017. For this year only, CMS is allowing that you report for a 90-day performance period only. So if you recall, in the Meaningful Use program, we had these more limited reporting periods. Instead of having to cover the entire year on reporting, you could report on a more narrow window. And similarly for MIPS, in 2017 only, you'll be allowed to report for just a selected 90-day period. And thus you can be ramping up now, and with the goal of using the last quarter of the year as your performance period. And you can choose to do more than 90 but less than the full 364 days if you choose that as well. The reporting deadline will be March 31st, similar as it is today for PQRS. In the third quarter of 2018, you'll receive a report that provides you with your final score as well as detail on your performance on each of the components. That's very similar to today's Quality and Resource Use Report, the QRUR, that's made available each year. And then finally, the payment adjustments will start at the beginning of 2019. And again, the cycle just continues on going forward. Now remember, the very next decision one has to make under MIPS is whether you intend to participate as an individual or as a group. The score, the final score, is always assigned at the individual level, but you have the option of submitting data at the group level. And if you submit at the group level, all of the MPIs who bill under that TIN are going to end up with the same final score, individually assigned at the MPI level. And remember, if you choose the group option, it's all or nothing. So if it's a 6-person group, all 6 of you opt for group reporting. You can't have 4 report as a group and 2 report individually. And finally, remember, we have 3 components on which you're going to report. And in addition to quality, we have advancing care information and clinical practice improvement activities. You will have to report on a group on all 3 or as an individual on all 3. The manner in which you submit your quality reporting are similar to what we do today under PQRS. An individual has the option of submitting submitting quality data by Part B claims. And this involves appending an additional code to claims to indicate to CMS that the appropriate process of care has been followed in delivering care to that individual. Individuals or groups, if you report as an individual or as a group, you have the report of using a registry, either a qualified clinical data registry, a qualified registry, or you can report using your EHR. For those of you who have a system that allows for the collection and submission of quality data, you can report using an EHR. And then for groups with more than 25 members, you have the option of using the CMS web interface, provided that you register prior to the end of June of this year. Both individuals and groups reporting through claims, registries, and EHR are going to report on 6 measures, not the 9 from PQRS. We're cutting the number down to 6. One of those has to be identified as an outcome measure. No longer do you have to worry about being in different domains per the National Quality Strategy. Just 6 measures, one of it has to be an outcome measure. The alternative is to report on a specialty-specific measure set, meaning that you would report on 6 measures from your particular measure set based on your specialty. Or if your measure set has fewer than 6 measures, you simply have to report on the measures in that set. The data completeness requirement for 2017 will be 50% of your Part B patients, similar to the PQRS rule for individual reporting. That number will ramp up to 60% in 2018, and we expect that that eventually will return to the 100% of Part B patients that had been in the proposed MIPS rule. For those who elect CMS web-based interface reporting, you will report on the 15 included measures for the selected sample of Part B patients. And that sample is in the range of slightly fewer than 300 patients you have to report on each of the 15 measures. For those of you who are part of a Medicare Shared Savings Program, ACO, you would be used to this web interface reporting, so that's what's utilized for MSSP reporting. Here is the list of the identified specialty-specific measure sets. You'll see that there are sets for general oncology, radiation oncology, rheumatology, and urology, relevant to our audience today. Radiation oncology is an example of a measure set that has fewer than 6 measures in it. And thus if you reported just on the 4 measures within radiation oncology, that's going to satisfy your requirements for this measure. For the number of measures on which you have to report. As I mentioned, you have to report on one outcome measure. And the one exception here is if you are reporting on a measure set and that measure set does not have an outcome measure identified within it. And then in that case you would have to report on at least 6 measures in the set, or again if the set does not have 6 the required measures within the set. If your measure set does have an outcome measure, you must report on that measure unless you are unable to do so by the selected method. And we'll describe the methods of submission of data in a few minutes. Here you see on the screen some examples of outcome measures. There are about 120 outcome measures that are identified by CMS. The difference here between a process and outcome measure, a process measure simply is in providing care for this patient I did X. So if this patient, for example, reported as a tobacco user, I provided tobacco cessation counseling. That's a process measure. Versus an outcome measure where you're actually looking to see that the care provided was making a difference. For example, control of hypertension is looking that you are keeping those patients diagnosed with hypertension within a certain range on their blood pressure. That would be an example of an outcome measure. Now once we've reported on our measures to CMS, what's the magic formula to calculate the quality score? And it's going to go through several steps here, so please bear with us. First of all, there's actually a 7th measure that will be considered in calculating quality scores, which is the all-cause readmission measure. CMS will calculate this using claims data, and it will only be considered if there are a minimum of 200 cases. You have to have 200 admitted patients for this measure to apply to you. It will be either applied at the group or individual level. So if you have chosen group reporting, that minimum number of cases is applied across the group. If you choose individual reporting, it's going to be for that individual physician having at least 200 cases. That may be a factor in choosing between group and individual reporting. The next step then, once we have all 7 measures, CMS goes through a point conversion process. So it's going to take your score. Say you have a score on a measure of 88%, which seems like a reasonably high score, but remember that all of these measures are evaluated relative to historical benchmarks. So CMS in late December published historical benchmarks for all of the MIPS measures based on prior reporting periods, and has published those benchmarks. The benchmarks are reported as deciles, so by each percentage. So the top 90%, those who performed at the top 90% level, their score would have been in that particular decile. Down 80%, 70%, and so on and so on. The deciles each equal a point. So if you are at a higher decile, you're going to get a higher number of points. If you fall in decile 2, you're going to get 2 points for that score. If you fall in decile 8, you're going to get 8 points of that score. If you report on fewer than 6 measures and you're not within a protected specialty measure set, you're going to get a 0 for that particular measure. CMS will also allow you to will allow you to report on multiple measures. So if you choose to report on more than 6, they're going to take your top score. So if I report on 10 measures, CMS is going to say, okay, out of those 10, we'll look at all of them, we'll score them on which 6 did this provider have the highest score. We'll use that in calculating the quality score. Now of course there's an opportunity for extra credit. One can earn bonus points in 2 ways. If you use chart reporting to generate the data submitted to CMS or to the registry, you can earn 1 extra point per measure. Also, you can earn additional points by reporting on additional outcome measures. So if instead of just reporting on 1 outcome measure, you report on 2 or 3 or 4, you're going to get an additional kick-up point number for that. So for example, if I choose to report on one outcome, I report on my 1 outcome measure, and I end up in the 8th decile, I'm going to get 8 points. But for the 2nd outcome measure, let's say I end up in the 7th decile for that measure, I'm actually going to get 2 additional points, which will kick me up to 9 points for that particular measure. And of course there's also 1 additional point for any high priority measure, and again they are all identified as such. And we simply cap the number of extra credit points you can receive up to 10%. So finally, your quality component score is calculated by taking your total points on the 7 measures, or 6 if you don't qualify on the all-cause readmission. And then we make appropriate adjustments for bonus points, and then adjust for measures for which you do not have a sufficient number of cases. So you will not be penalized under MIPS if by the size of your practice you do not have a sufficient number of patient volume to generate the necessary score on measures. Here you see an example of how the deciles are reported out. You can see how different scores will generate a different decile points. And then in terms of historical benchmarks, you remember you are competing against prior reported performance on that specific measure. The benchmarks vary by submission measure. We'll come back, your submission method, we'll come back in a minute and talk about that. MACRA, the legislation again, requires that benchmarks be published each year prior to the start of the performance year. So CMS published the 2017 benchmarks on December 28th, none too early. Here you see the link where you can access those benchmarks. Go on this link to Documents and Downloads and click on 2017 Quality Benchmarks. Here I just did a pure cut and paste to give you an example of how these deciles look when reported. So it's giving you the name of the measure, its ID number, the manner in which it's submitted, the type of measure, remember process versus outcome, and then it gives you the decile range on this particular measure, just as an example. And when you go to the benchmark list, there are literally pages and pages of this data. So I'll take a break here.
Yep, Marty, that was great. Particularly excellent in regard to the fact that we were getting a lot of questions submitted online. And it seemed that almost within one slide of the submitted question, you had the answer coming up. So it was a very comprehensive review, and I think it addressed a lot of the issues that are out there. What I want to do is get some questions into Robert in particular, because I found it interesting when he commented on his EMR and that they were fortunate that it was able to perform a lot of the reporting, had a reporting module for PQRS. But Robert, as you go into more sophisticated reporting, have you thought about already acquired or in the process of acquiring other IT solution software, hardware, consultants in order for you to get to where you need to be as you move to APM?
Yes, and I think that's one of the things that we've discovered is during this first phase of all the quality reporting and everything we've done, because we're a practice that has a core of oncology with radiation oncology, medical oncology, and urology. So we had a generic, not a specialty specific EHR that we were able to take the common, MIPS and PQRS and PQRS and MU2 reporting measures and be successful across our group. And so what we've found out is as it becomes more sophisticated, more challenging to do reporting, and particularly as we start to get into, the APM models of oncology care model, we actually have been going back and we've developed a MERS engine that is a data warehouse engine. So we've had to create and put together that so we can kind of dump any data from different systems that we have connected to our EHR, because we have a system for chemotherapy ordering that's separate from our EHR and a system for radiation oncology separate from our EHR. So pulling that data and dumping it into our data warehouse and then using a product called Tableau to kind of make reports so we can track where we're at for things that aren't already in the canned reporting system from our EHR. And it's becoming more and more that our canned reporting system from the EHR doesn't have that. So we're developing our own reports. We've beefed up our IT staff in the last few years, and fortunately our IT director is very aware and very involved in all the data reporting requirements. So she keeps up to date with that. And it's really been beneficial for our practice. But we are in the process now of looking at outside consultants to help us with some of this data reporting. And we are also reviewing other EHR systems that are now more specialty specific that might meet our needs a little bit better as we go forward in these advanced models.
All right, so that's excellent.
Yeah, so I think in a nutshell, we feel like we've stretched our current HR about as far as we can.
Mm-hmm.
All right, so Marty, let's get into the measure selection criteria.
Well, this is where we transition from the science to the art of figuring out to maximize my MIPS score. I want to maximize my quality component score, which means I need to maximize my individual measure scores. And the key there is selecting the right measures on which to report. Now, obviously, again, you can report on more than 6, and certainly you can compile the data and then select on which measures you're going to submit. But there's some key considerations here that are part of this decision-making process. The first is, of course, your prior reporting experience. If you have previously reported through a registry, a qualified clinical data registry such as the Quality Oncology Practice Initiative, that's certainly going to inform your decision making on quality measure selection. For PQRS, you have gone through the process of selecting measures on which to report your 9 measures across 3 domains. But remember, the motivation under PQRS was all about ease of data collection because the penalty was tied to reporting. Now, while the value modifier evaluated your performance on those measures, it was fairly far removed, and really the driving motivation was, can we collect the data and submit it in an efficient manner? With MIPS, the game's changed, and now it is about achieving the highest possible score on your selected measures. So certainly you can start with your familiar PQRS measures, but do not automatically select these as the measures on which you want to report. Because as you will see, the benchmarks have a significant impact on your ability to score well on particular measures. Certainly you want to look at practices measures that are relevant to your practice. There are 271 MIPS measures, a slight reduction from PQRS. Here you have a searchable database where you can slice and dice the measures to take a good deep dive look at them. And if you want to go even further, CMS has provided for each measure a detailed spec sheet, which in particular focuses on the definition of the numerator and the denominator for each measure. And you can access that information at the website shown here. Importantly, you have to consider your performance capacity as to each of the measures on which you would potentially want to report. You have to take a look at those historical benchmarks because again, what you think is a good score at 88% may in fact put you at the 3rd decile. In fact, for many of these measures, because of the nature of the historical data being used to generate the benchmark, many of those decile scores are very high. And it again varies by the manner in which you select to submit your data. There are also a number of measures that are topped out, meaning that it appears that the providers across the board are adhering to that particular quality standard, and so there is very, very little room for error. That missing 1 or 2 patients could push you down 1 or 2 deciles on these topped out measures. And again, look for those opportunities to optimize your bonus points. In fact, it seems reasonable to me that I would begin by looking for 6 outcome measures on which potentially I could report, given those additional bonus points for reporting on those types of measures. At a minimum, I'd be focused on the high priority measures that will at least get you 1 bonus point, again, kick you up 1 decile by reporting for those measures.
So Martie, we've had a pretty extensive conversation about the performance measures, but that's only part of the story. The other part of the story is submitting those measures. And that in and of itself is more complicated than it would seem. Take us through it, please.
Sure. CMS has provided multiple measures for providers to submit their data on their selected quality measures. That's similar to what we have today under the PQRS system. However, one needs to appreciate that not all measures can be reported by all of the available mechanisms. So there is the opportunity to submit through Part B claim submission. There are registries, and there is methods for submitting utilizing your electronic health record. But for each of those submission types, there are only certain measures that can be reported. Also, there are certain methods that are only available to certain types of providers. For example, submitting your data through Part B claim submission is only an option if you are reporting as an individual. Groups cannot utilize this reporting mechanism. Also, there is the opportunity to use the CMS web interface, but again, that option is only available to groups that have 25 or more eligible clinicians within the group. So that also limits opportunities for reporting. Again, just briefly reviewing the 4 methods of submission, beginning with Part B claims. This is not simply relying on CMS to gather data using your claims data. Instead, it requires the individual provider to include in their claims an appropriate HCPCS code, which demonstrates that as part of the service delivered, the specific quality measure was also satisfied in delivering that care. The other challenge here is this truly requires real-time submission. So it is impossible to go retroactively and assign or include in your previously submitted claims data relevant to the quality measure. So if you are opting to use Part B claim submission, you need to make that decision affirmatively prior to your specified performance period. And again, remember here in 2017, you have the option of limiting your reporting period to 90 days. So claims B, Part B claims reporting is still on the table should you elect to report for a shorter period of time. Second option is through your electronic health record if your particular product has the capability to accomplish this. You need to discuss that with your vendor to see if this is an opportunity. It is a passive approach in that the information is gathered from your EHR and then loaded and submitted to CMS by the vendor. Third option are registries as well as qualified clinical data registries. To participate in a registry, a provider, an individual provider or a group, this is an option available to both, collects data during the reporting period. It is then aggregated by the registry and submitted to CMS in the beginning of 2018. There are a limited number of registries available. One has to do their homework and select what works best for them, whether a general registry or a qualified clinical data registry, which is typically tied to a professional association. And it's important to note here that this is your best option in terms of breadth of measures. So you see that there are well over 200 of the measures that are reportable through registries. Finally, there's the option of the CMS web interface. If you have been involved in an MSSP ACO, you are most likely familiar with the web interface because this is the tool utilized to do MSSP quality reporting. But in the web interface, there are 15 specified quality measures on which the provider, the group will report. And you will go into the web interface and there will be a select number of identified beneficiaries, approximately 250. You're required then to report on that select group of patients with regard to those to those 15 measures. So those are your options to consider for reporting. It is important not only to make sure that the measures you want to track can be reported by your selected submission method, but also understand that the benchmark scores vary for the same measure based on the submission method. The legislation, MACRA, requires CMS to publish benchmarks prospectively. And in fact, CMS released the benchmarks for 2017 back on December 28th of 2016. There's truly no magic math here. Heaven knows we've tried to figure out if you have the most measures with the most favorable benchmarks in one of the 4 submission areas. There's really no rhyme or reason. It is an individualized inquiry to figure out where are the 6 best methods for you to report based on the benchmarks by submission method. Just to give you an example of the variation, here we'll take the example of the measure for tracking of pain intensity in oncology. And you can see here looking at the submission by EHR versus by registry. For practices that have historically submitted on this measure using EHR, they are topping out at 100%. So if you were to choose this measure and to report utilizing your EHR, you would only receive credit if in fact you met this measure for every single patient. Now compare that to having the benchmark for using this measure and reporting through a registry. See that you could have performance at just a hair over 90% and receiving 6 points. So there could be significant variation with the same performance by the providers, but the varying point levels depending on the method by which you submit that information. Another example here of documentation of medications in the medical record. Here there are 3 different methods for submitting data on this particular measure. And you can see from the data here on the screen the significant variation where you have 2 providers that score at just a hair over 96%. That provider submitting through claims is going to only receive 3 points, while the provider that submitted through electronic health record is going to receive 6 points for the exact same score. Finally, one consideration on topped-out measures. Topped-out measure is one where the industry has really developed and followed practices that ensure nearly 100% compliance with the measure. And so it truly has become standard of care to adhere to this measure. You can see here that the number of topped-out measures again varies by submission type. And as we discussed previously, the need to avoid topped-out measures because you are putting yourself into a position of really not having that opportunity to gather as many points as possible. So let's stop there. Bruce, anything we want to discuss with regard to the submission methods?
So Marty, unfortunately we're running tight on time, and I think with the time remaining we'll just make it through performance improvement initiatives. So let's jump right in.
Okay, and here we just want to talk some very practical pointers on how once we've selected our measures, once we feel comfortable with our submission method, really what should we be doing within our practices to maximize our scores? And so it's just very basic performance improvement. And not only to maximize our scores, but really in many instances to improve the care provided to patients. So certainly within your group, with regard to your selected measures, it's critical that you understand the denominator. So who are the relevant patients for this particular measure? And the denominators have very specific exclusions, and appreciating patients that fall in a broad category, but for various reasons are going to be excluded out from the measurement pool. Second key point is to understand the numerator. What exactly has to happen for each of the relevant patients? What's the task that has to be completed, the data that has to be gathered, the interaction that needs to occur? Next then is really the active part of performance improvement, that take a snapshot of where your current performance is on this particular measure. Not necessarily a deep dive audit, but pull a few charts, have some discussions with folks, see what's going on with regard to that performance area. Then it's a matter of evaluating your current clinical workflow. Where in your process, from the time the patient comes in the door to the point that you drop a claim for that service, where in that process are the opportunities to interact with the patient or to gather information or to record data that's going to be relevant to that measure? That's going to key for you where the process improvement opportunities are, where you have that time or staff available or the opportunity for the patient to complete information that's relevant to the measure. Where are those opportunities, and where can we insert changes or insert processes that are going to help us meet the particular measure? And then once you've identified and implemented those process improvements, it's critically important to go back and evaluate how that process is working and, if necessary, modify the improvements. Last position you want to be in is to think you've solved the problem in March and then find out in December that the process had broken down and you had not taken the opportunity to ensure compliance in that particular measure. Very quickly, I want to take an example again of a measure we mentioned previously, which is quantifying pain intensity for oncology patients, and walk you through this performance improvement process. First key point is, again, understand that numerator and denominator, understand the purpose behind this measure and what we're attempting to accomplish. And there's significant, again, we've mentioned this previously, the QPP website, qpp.cms.gov. Under the section on documents and downloads, there is extensive reference material regarding all of the measures that are part of the QPP, and it will include the rationale for the measure as well as the clinical recommendation statements that are pulled from all of the professional organizations as well as the National Quality Forum that were involved in creating this measure and validating this measure. So that's critical information to gather for your selected measures. Your first step, of course, then once you have the measure is identify that denominator, all the patients to whom this particular measure is relevant. And here we know that it's oncology patients that have a current cancer diagnosis that are undergoing chemotherapy or radiation therapy. And we need to make sure that in each episode of care that pain is being quantified and recorded. So how do we accurately flag those patients that we're going to make sure we need to have this interaction with? What's the administrative step in the process? Is it simply noting something in the EHR? Is it part of the patient flow as patients go from the waiting room into the exam room? What are medical assistants or nursing staff doing to ensure they're capturing this data? Remember, this is a quality measure in this case with pain intensity that does not necessarily have to be a physician interaction. This is data that can be gathered by staff and then made available to the physician for their decision making and their interaction with the patients. Of course, second piece of the puzzle is capturing the necessary data. Again, for this measure, if you dig into the commentary, you see suggestions on different methods that can be used to capture this data, everything from the common 0 to 10 scale to using the happy faces to just capturing information from the oral interaction from the patient of how they are describing their pain. And then ensuring there's a method to capture this in the record, so that when you come back to ensure compliance with the measure, that data is there. It's the good old, if it ain't documented, it didn't happen line in healthcare. Finally, in step 3 are those opportunities to take the data that is gathered through this process and actually utilize it to improve care. So if you are receiving a report from a patient of significant pain, what other additional information do we need to gather to understand the triggers of that pain, or what in their daily environment is causing or increasing or relieving that pain, and having those conversations with both family members and caregivers. It's looking for a course of action for the patient when they experience pain that's increasing or when they're experiencing very intense pain, making sure that that patient and their family has a strategy for addressing that pain. And finally, sharing that information with other providers who are part of the patient's care continuum to utilize that data being gathered through quality measure compliance then, and again, sharing it for purposes of patient care. So it's a very simple, straightforward process. It's just a matter of stopping and evaluating your system and looking for those opportunities for improving care delivery, which then in turn is also going to improve those scores on your selected MIPS measures. So with that, we have gone through our substantive information. If there's any additional comments to be made, Bruce, we can wrap this up.
Thanks, Marty. That was great. Unfortunately, we're out of time. I do believe that we did get to many of the questions that were coming on through the chat.
So with this, let me say I want to thank you and our speakers, thank the audience for joining us for the second webinar. Hoping you'll be staying tuned to the third webinar in a few weeks. And I'll pass it back to Keith for final housekeeping comments.
Thank you, Bruce. Just a couple of notes. A MACRA helpline is going to be available to webinar participants for 2 weeks following the meeting. You can just email Martie at mross@pyapc.com. And we also have a Cardinal Health email address that's available to answer questions at macra@cardinalhealth.com. You'll also receive a recording of today's webinar and a copy of the slides. And also, we just recently launched our MACRA Resource Center at cardinalhealth.com/MACRA. So be sure to visit that website for more resources and additional webinar recordings. Thanks, everyone, for joining us today, and we hope to see you on our next webinar.